Okay, friends. So we are live. Shilpa ma'am, you can start.
Yeah, welcome to the Masterclass 2. So today is about the safe entry of the primary port or even the secondary ports. I thought this topic is very important because majority of us, when we start doing laparoscopies, we find lot of, I think, hindrances or inhibitions when we want to put that port because it is a blind procedure. So today we will get more practical tips as to how to tackle these issues and how to actually manage the problems if at all if we encounter, and how to actually become a master in putting the trocar within like few seconds. Yeah, please take over, you can start.
Okay. So again, what is very simple to understand as far as putting trocars is concerned is that even if you are putting Veris trocar, okay, or Veris needle basically, or going with a direct trocar entry or whatever you are doing, the first step which you do in laparoscopy is a blind step most of the times, unless you do an open technique. Even in the open technique, you are dissecting till the peritoneum, tenting the peritoneum a little, and after tenting the peritoneum you are going inside, correct, in order to enter the abdomen. But otherwise, for laparoscopic surgery, in almost all other cases, you have to choose a point to enter in such a manner that when you enter you are safe, and second, you are straight intraperitoneal, right? Certain cases only you have to be retroperitoneal, that means extraperitoneal. That is when you are doing a retroperitoneal laparoscopy, especially when you are doing retroperitoneal para-aortic lymphadenectomy or ureteric dissection or whatever is the situation. But otherwise, in gynecology, majority of the indications are for an intraperitoneal surgery. Okay, fine. So what are going to be the two things which we need to keep in mind? Remember one thing. There are two places where you will experience resistance. One is the rectus sheath and second is the peritoneum. Okay. So when we say we hear two clicks, many times people are putting their ear close to the Viris needle and trying to hear those two clicks. Those two clicks are not what is going to be heard by you. Those two clicks are going to be actually felt by you. It is a haptic feedback, right? The first time you pierce the skin and you go in, there is nothing in the abdomen till you touch the rectus sheath. After you pierce the rectus sheath, you may feel that there is anterior rectus sheath, there is muscle, and then there is posterior rectus sheath. But remember, posterior rectus sheath is, it's not very strong. Okay. Posterior rectus sheath is a very Jay Mehta like structure, very normal, simple, pliable structure. Understanding? After that comes the peritoneum. And peritoneum is a very thin structure. So after your first click of that rectus sheath, which is going to be little strong, that second click is going to be, the second haptic feedback is going to be much more milder as compared to the first haptic feedback. This is actually what you need to keep in mind, right? Apart from this, I think there is one very, very important thing which I'm going to actually draw and show. So just let me just draw that, because you will understand it in a very beautiful manner if I draw it. Just let me show it. Shilpa madam, just see if you can see my this thing screen.
Yeah.
Yeah.
Yes.
Okay. Wait, huh? Okay. So this is the anterior abdominal wall. This is the umbilicus here. This is the abdominal wall above. Okay. So this is the pubic symphysis. Let's put it that way. Okay. Underneath that, let me just draw it in a different color. You have rectus sheath like this, coming into the umbilicus here, and rectus sheath going out like this. Okay. Underneath that, you have the muscle. Let me draw muscle in a different color. So underneath that, you have the rectus abdominis muscle. All this is muscle. There is no muscle here. Okay. And then again, there is muscle going like this. Then there is a posterior rectus sheath. Very powerful, small, thinned out structure. Okay. And then you have the peritoneum. This is your peritoneum, right? So umbilicus is chosen at a point because from the skin of the umbilicus, which is somewhere here till here, this depth is the least. So your entry length is the least. That is why people prefer to do it in umbilicus. But as you advance in your surgical skill, you will go up in life. So you will go, instead of umbilical, you will go supraumbilical. Okay. When you go supraumbilical, remember one thing, start using your umbilicus to give a grasp. So what do people do? They put one thumb inside the umbilicus and they try to lift the umbilicus up. Correct? When you lift the umbilicus up, the most important thing you have to remember in life is only and only this, that your trocar, okay, let me just draw the trocar, that your trocar has to go perpendicular. Always trocar has to enter perpendicular. Majority of the times what happens is the minute we touch the rectus sheath here, our trocar will bend towards one direction of the abdomen. Actually, our trocar, if you look at 99% of the surgeons, no, our trocar will bend towards the right side. Okay, towards the right side of the patient. Don't do that. After you pierce the first resistance, that means after you pierce the rectus sheath, trocar should go down perpendicular only. You should not put your trocar in a horizontal manner. By putting the trocar in a horizontal manner, for example, if I put the, show you how it goes. If you go horizontally, you are increasing this length of your insertion. When this length of trocar insertion increases, most of the times you will stay extraperitoneal, and that is your problem. Because you are extraperitoneal, you will get frustrated and you will form a tract which is completely ada teda tract. Okay, so that is something which is a very important take home point in any of laparoscopic port entries. As far as port entry is concerned, never ever do a port entry in that manner that you get confused. So just showing you the trocar, if this is the trocar, and if my 1 minute. Yeah, so I hope you can see. If my hand is the trocar, I mean, if my hand is the abdominal wall and my trocar is here, okay, what we normally should do is you use your index finger to guide you. That means many a times you are worried that if you go very deep, you may puncture the vessel, because we are taught, no, our common MCQ in laparoscopic surgery is if you hit the first structure which you are going to hit is the common iliac and this and that and whatever. So just remember, use your index finger as your guide. Pierce the skin. Now, when I pierce the skin, I've reached the rectus sheath. When I reach the rectus sheath, that is when I lift the umbilicus up. Till that time, don't lift the umbilicus up. Till you pierce perpendicular, lift the umbilicus, and then just go inside with one more push. With your index finger, maximum you will be entering just intraperitoneal. You will not be digging deep. Okay. Obviously, when we are talking of safe trocars, and once you have begun to put trocars, or once you have put viris and you are not putting in a direct needle or whatever, there are 2-3 things which you have to understand. If there is a scarred abdomen, what happens in a scarred abdomen? How do you choose your entry point? So remember, in a scarred abdomen, majority of the times it is going to be only structures which have mesentery, which will come because they are mobile structures, and only they can come to get adherent. So what is the commonest structure which has a mesentery and who has that uncontrollable itch to go and get adherent? The answer is omentum. The second person who has the similar itch is ileum, that is small bowel. So if in case you have a scarred abdomen somewhere and you decide, oh, this is a scarred abdomen, how much distance should I maintain to put my primary trocar? Okay, remember the safest answer is 5 centimeters, because that scar is what you see on the surface. The adhesions are formed inside, and underneath that is going to be the peritoneum and rectus sheath where things are actually adherent. So it could be that the adhesions are within that radius of 2 to 3 centimeters surrounding the scar. So maybe a 5 centimeter radius is a good radius for you to enter inside. Okay. One more thing I want to tell you, no method is absolutely safe. The amount of vascular injuries, bowel injuries, everything happens with everybody. It happens with varus also. It happens with direct trocar also. It happens with everything. Okay. There are many people who like to use an optical trocar and say that when I use an optical trocar, I can see everything. You can. But if the bowel is adherent to the peritoneum very snugly, you will see your trocar entering the bowel. You will not be able to separate the bowel from there. Understanding? So don't get into an illusion that an optical trocar is going to reduce your rate of injuries. Don't get into that illusion. In fact, what I'm showing you is an optical trocar, and I have never used an optical method to put this trocar inside. Right? So keep that in mind. One more thing. If in case you have put a trocar and it has gone through the bowel, and you have realized it has gone through the bowel, okay, then kindly put an additional trocar, let that be there, so that you will see your injury very nicely, okay, and you will be immediately able to suture it. It's a very important point. People often make a mistake. People in that hurriness take out the trocar, and the bowel which has been injured goes up. Understanding when it goes up, you are going to have a tough time finding that injured place in the upper abdomen. Okay, keep that in mind. Give your head low and insufflation of the abdomen only after you have verified that your primary trocar has entered the peritoneum. Do not put a trocar when the patient is in head low position. Do not put a trocar when the patient is in lateral tilt position. The patient has to be absolutely supine for you to take advantage of the anatomical things of putting in a trocar, right? So with this, I finish my 10 minutes of talking. I will give it back to Shilpa madam, and madam can ask questions. And I think those are the questions which we will want to answer.
So I think you always do a direct trocar entry, and I
Always.
prefer to do the Veris. So of late, I have not seen many youngsters use the Veris needle. So what is your thought? I mean, is it a futile exercise to do the
It
Veris?
is not a futile exercise, madam. It is a part of your training. I know many people who are absolutely comfortable with Veris, and I know many people who are simply not comfortable with Veris.
So what is your thought on these blunt trocars, which say that they are more safer than the sharp trocars, like the one which has a guard, like which just goes away like a spring?
Madam, it is a mental comfort rather than an abdominal comfort. You know, it has got nothing else to do with the... See, I have had a patient, or I have had quite a few number of patients where blunt trocar has caused shearing injury on the bowel. Okay, and then it has come back to us with a fecal peritonitis, and we have repaired it. Okay, so I don't believe in that, madam.
So what happens in thin patients? I mean, do you take extra precautions, or it is still the two clicks that you will hear? And
Madam, I think, to be very honest with you, after you get enough experience, you don't want to hear those clicks.
yeah,
If you are in the abdomen, you will know you are in the abdomen. If you are not in the abdomen, you will know you are not in the abdomen, right? Your haptic feedback becomes ingrained in your head.
Yeah. So if there is already a scar of a previous laparoscopy, do you always go through the same scar, or do you recommend better? No. Yeah. And so somebody is asking about inferior epigastric vessel injury. Does it?
I see. We never try to look for a illumination and identify the inferior epigastric. Try and understand that. Okay, never do that. What you are actually going to do by illumination is look at the superficial vessels and not deep vessels. And the inferior inferior epigastric artery is located in the rectus muscle. Okay, so it is no point trans illuminating the rectus muscle. You should have a marking boundary for the rectus muscle and go lateral to it.
So depending on the number of scars, do you change your entry site, like to a Palmer's point or a Jane point, or like, you stick to the same thing? What is your recommendation?
Madam, I think you have seen me operate quite a bit, right? So what is important is in any of this methodologies, or what to say, in any of these situations, I personally think what is important is this. You will have to assess an individual abdomen on an individual basis. One can't really say that I will go through Palmer's point only. One can't really say that I will go through Jain point only. One can't really say that I will make this entry only. That's not correct. Okay. Based on the scarring in the abdomen, you have to look. And based on the scarring in the abdomen, you will have to take one call as to where to enter. And then once you take that call, you just enter. Remember, the biggest problem with any lateral entry point, be it your lateral trocar, Jain point, Palmer's point, whatever. I think, again, I am coming back to the same thing. It is the lateral abdominal wall. What do people do? First click they hear, see how their hand movement will be. First click is this, then automatically hand will become tilted like this. And then they will try to dig in. So they have created a lateral tunnel in that peritoneal region. Never do that. In order for you to keep your length, I've shown it so many times. If my abdomen is inflated like this, my trocar should be standing perpendicular to that abdomen. So I have that length to maneuver the trocar. If the trocar has gone in an oblique direction, see, this is how it goes. Can you see that? And if it goes like this, it does not move very nicely inside that abdomen because the tract is big. Simple physics, right? Try to avoid that. Nothing happens.
So, if it is pre-peritoneal, many a times it is pre-peritoneal and the pressure is like, quite high and you still go on inflating because you are not sure and things like, go the wrong way. So how do you tackle it? I mean, if you are in pre-peritoneal and then you realize, so how?
Deflate it. That is the best. The best is to deflate, come out. Okay. The best is to actually keep the trocar there and deflate.
Correct.
Okay. So through that length of the trocar, majority things come out. What do people do in hurry is they take the trocar out also.
Yes.
Remember, it is a dead space. So what will happen is that dead space will form something called as peritoneal emphysema. Okay. And that will obstruct your vision in surgery.
Yeah.
So simplest option is when you go back in the peritoneum again, no, make a nick on the peritoneum. Whatever gas is inside, it will come in the abdomen. And the peritoneum will simply get, deposited back to its original position.
So some people say put 5 mm trocar and then change it to 10 mm if you have a doubt that there is any adhesions and all that. I mean, have you ever done it? Do you recommend doing it?
No, I don't know. I mean, I can't be giving out a recommendation like that, but I have never done that.
And if at all, if you on entry, if the stomach is distended sometimes, so if you make a nick on the stomach, so what do you do in that case with the trocar or with the Veress needle?
Just remove the trocar and suture it. See, stomach is like bladder, very forgiving organ. Stomach is most of the times collapsed. The stomach is expand only when you are eating food, or it will stay expanded if you are continuously eating food, right? That is something which is not going to happen in a normal physiological condition, no? So stomach, if you keep that stomach on rest, correct? I'll give you an example. If you do bariatric surgery, what do? You are stapling through that bariatric line. Okay. It's the same transfer stapler. It's not some stapler which has come from Mars. Okay. So the same stapler is used. You cut through the abdomen, you reduce the length and it staples the abdomen. Once it staples the stomach, people are allowed to eat food. People are allowed to eat all diet which they want to eat. Correct. In the next 24 hours or so. Correct. So if you have a stomach injury, all you can do is you can take PDS or maybe you can take 20 Vicryl, suture it. Once you suture it, patient can keep her ice tube for 24 hours. It will heal. Stomach is a very good organ to heal. Trust me.
So for all the youngsters out there, to begin with, okay, so first in their training, they start with the secondary ports and then they go on with the primary port insertion. So secondary port is usually under vision. So they start learning the haptic feedback and then they go on to do the primary port. So
that's correct.
To make it like, something speed tracking this whole process. So do you have any tips like how they can actually do the primary trocar insertion without struggling? Is there, or is it they have to go through this?
Everybody, I remember this. See, I've spoken about it many times. So when I was a PG, Dr. Ashwath used to have a diary on which we were supposed to take his signatures. 100 cases you are supposed to assist vaginally, then you get to put the right trocar. 50 cases you put the right trocar, then you get to put the left lateral trocar. 50 cases you put left lateral trocar, then you get to put the primary trocar, right? That is the curve. By putting 50 things from your right side laterally, you will have almost got that haptic feedback. Then you get that same haptic feedback from your left hand as well when you put that left lateral trocar. After that, when you move to your primary trocar, you have put 100 trocars under vision. So you will have that idea. You will have that idea. First time when your trocar goes inside, you will feel as if you have done radical hysterectomy in 5 minutes. Correct. That is the amount of emotion it generates. Correct. No. But I think what is very important for every surgeon to note is that primary step you need to be very careful, because that is the step which can make or break a surgery when you are into advanced surgery. Correct. And that is the step. I mean, if your primary trocar goes in nicely, you know that your vision is good. It has not gone through the omentum. You will be able to manage the rest of the surgery.
Yeah. So, the primary trocar, I have seen you do it supraumbilical most of the times, and
yes,
don't change the primary trocar site.
No.
Even if it is a large uterus, or even if
no recommendation to change, because round ligament uterine artery as well as ureter. Everybody is retroperitoneal and everybody is located at the pelvic brim, or everybody's dissection begins from the pelvic brim. So even if you have a 36-week uterus, it doesn't really matter. The structures which matter are going to be down only.
Okay. So yeah, I think this is all it is. Yeah. So any questions, I think we can answer it on WhatsApp.
So I want to tell one thing in the end, and I think this is for all the youngsters. If you are a youngster, or if you are an old timer, or if you are whatever, okay, kindly switch to using good quality disposable trocars instead of using your stainless steel trocars. I'm not saying that stainless steel trocars are good or bad. They are fabulous. There is no question in that. But remember one thing, there is some amount of blunting of the obturator which occurs on a stainless steel trocar because of repeated amount of autoclaving and plasma and all these things. Disposable trocars which you use are adequately sharp, and because they are adequately sharp, they allow you to enter the abdomen very, very smoothly. Okay. And because they allow you to enter the abdomen very smoothly, you are almost always in a good sort of a position to carry out your surgery with a lot of confidence because your primary step has gone right. Second thing, always try to use trocars which have these small types of serrations. If you can see, these serrations are good enough to grip inside the peritoneum and the rectus abdominis muscle and the rectus sheath, these serrations. Okay. These serrations will keep the trocar stable. Okay. And they will help you. And finally, one thing, many people have this craze about using open technique. Okay. So I want to give some explanation about the open technique. Remember, in open technique, what happens is your 10 mm incision is never going to be 10 mm. Your 10 mm incision actually becomes 12 to 14 mm in an open technique, right? So you are actually giving a larger skin incision and then you are really retracting the hell out of it in order for you to go and puncture that rectus sheath very nicely. I personally think open technique is a very good technique. There is no denial, but in open technique, very strongly at your closure, close the rectus sheath. Because in open technique, mandatorily your rectus sheath will be opened with your scalpel, and the opening will not be a small opening, it will be a large opening. Because it will be a large opening, fibers will be cut, and in open technique, when you finish, it is better to close the rectus sheath. Otherwise, closure at 5 mm rectus sheath and 10 mm port for rectus sheath is not even recommended because it doesn't herniate so easily. Okay. So that is just something which I wanted to add.
The serrations you mentioned, right? I mean, initially it's kind of difficult if we are used to this steel trocars, I mean, this kind of gives that resistance, and also you're not confident of an easy entry. So it kind of makes it a little difficult. And also, I don't know. I mean, I wasn't very comfortable doing it. But maybe it is again like a couple of times you do it and then you sort of get used to it. Yeah. Any which ways, thank you so much. It's all good. I think the basic points have been covered.